dislocation, complete loss of glenohumeral articulation, partial subluxation is partial loss of glenohumeral articulation, and laxity is incomplete loss of glenohumeral articulation with unassociated with pain. So there are some stabilizing factors which are divided into a static and dynamic. Static factor are like articular congruences, articular version, glenoid labrum, capsule and ligament, and dynamic factor like rotator cuff, bicep tendon, scapulothoracic motion, negative pressure and proprioception. Shoulder stabilizer, just a diagrammatic presentation. So coming to osteology, it's a glenoid fossa which is pear shaped, 7 degree of retroversion, 5 degree of superior tilt. Glenoid version is 30 degree anterior, humerus is neck shaft angle is around 130-140 degree, and retroversion of about around 30 degree. So static factor, normal glenoid is 7 degrees retroverted. Excessive retroversion causes the posterior disability. Glenohumeral joint, humeral head is like 3 times larger than the glenoid fossa. It's a ball and socket joint. Degree of freedom are like flexion, abduction, adduction, internal rotation, and circumduction. So glenoid labrum increases the superior inferior area by 75%, anterior posterior area by 50%. It's a static stabilizer. Fibrocartilaginous tissue deepens the glenoid, and the 3 main purposes are increases the surface contact area, buttresses and attachment site of glenohumeral ligament. The capsule and ligament attaches medially to the glenoid fossa, laterally to humeral neck. Anterior capsule is thicker than posterior, 2 to 3 mm distraction and little contribution to the joint stability. Superior glenohumeral ligament is a minor role in preventing the anterior instability, mainly effective in limiting the inferior translation and external rotation with arm at side and adducted. Middle glenohumeral ligament, primary effective at 45 degree of abduction, help limit the external rotation, inferior and anterior humeral translation. This is important. Inferior glenohumeral ligament, heavily involved in maintaining the shoulder stability, forms the hammock with anterior and posterior bands. Primary stabilize the limiting anterior, posterior, inferior humeral translation in 90 degree of abduction. Bankart lesion, we all know these are coracoacromial ligament, secondary stabilizer, and coracohumeral ligament contribute to the inferior subluxation with arm at side. Dynamic factor are rotator cuff, bicep tendon, negative pressure, shoulder, scapulothoracic motion, and proprioception. Rotator cuff, EMG MCU study have shown that all are active throughout the full range of motion. Co-contraction helps to hold the humerus held in the center of glenoid throughout the arc of motion and create the glenohumeral compressive force that stabilizes this joint. Long head of the bicep and deltoid, they are secondary stabilizer and head depressor, and periscapular muscle help to position the scapula and orient the glenohumeral joint, contribute the comprehensive forces across the joint. Scapulothoracic movement is 2:1. Scapulothoracic muscles are trapezius, serratus anterior, teres minor, and levator scapulae. Negative intra-articular pressure is minus 42 cm of STO in cadavers, secondary to high osmotic pressure in interstitial tissue. Only clinical importance is in the arm at the rest in adduction and loss of lax capsule or the defect. So instability, as we have discussed, it could be when instability is classified, it could be depending on the frequency, cause, direction, and the degree. So this is the classification: frequency, whether it's acute, whether it's a recurrent or fixed; cause, whether it's a traumatic or traumatic, micro-traumatic, or some congenital disorder; direction, anterior, posterior, inferior, or multidirectional; and degree of, like, is it dislocation, subluxation, or a micro-trauma. This is Stanmore classification. Polar type 1 is a structural instability. Polar type 2 is a traumatic instability. Type 3 is a neurological dysfunction or muscle patterning. So there is a various spectrum of the dislocation. It could be a traumatic, micro trauma, or traumatic. It could be a less laxity or unidirectional, or a more laxity or multidirectional. So this is the grading of laxity. If the grade 1 is a translation of humeral head with the rim, translation of the humeral head over the rim is grade 2, and over the rim and lockout, it's a grade 3. So what is pathoanatomy of shoulder disability is whether you have to divide into the labral lesion or a capsular lesion. Labral lesion like Bankart, reverse Bankart, or slab. Capsular lesion, intramuscular tear, Hagel lesion, and capsular laxity, bone loss either on the glenoid side or on the humeral side. So when you start see the patient in the instability, you have to evaluate. So whether what's the age, the trauma and the duration of the trauma, associated pain, sports, throwing or overhead activities, voluntary subluxation, clunk or knock, fear of limitation of the movement, history of dislocation and energy associated, history of first dislocation from the first dislocation and subsequent dislocation, or how many times the patient has dislocated. So physical examination include the inspection, palpation, range of motion, winging, neuromuscular testing, generalized ligamentous laxity and instability test. Certain tests for instability like sulcus sign, drawer test, load and shift test. Apprehension test for anterior instability, shoulder abducted to 90 degrees, slight stress to humeral head directed in the anterior direction while externally rotating the shoulder. Positive test is the apprehension due to feeling of instability or impending dislocation. Be aware of false positive. Relocation test, anterior instability after the positive apprehension, apply posteriorly directed force over the externally rotated humeral head. Positive test is the relief of apprehension, anterior release test. Shoulder instability imaging, the radiograph, CT based to assess the bone stock and 3D reconstruction preferably, and MRI with or without arthrogram and evaluate the soft tissue. So coming to the anterior instability, more than 90% of the dislocation are anterior dislocation, abducted and externally rotated arm, recurrent dislocation under 20 to 20 years of old, wide variation between this study, less likely as the age increases, male at higher risk and higher risk in contact sports. Rotator cuff are associated after the age of 40 years, and initial management is all we know is the reduction and immobilization. So you have in anterior instability, look for the Bankart, look for the whether it's a soft tissue or a bony, look for Hagel lesion, and the treatment recommendation. What are the treatment recommendation for anterior instability? Initial management is typically include the immobilization followed by range of motion and strengthening. First time dislocator management is controversial, but the young athlete and the military personnel should be considered for surgical management as per the literature. Immobilization in internal rotation or external rotation. Initially it was beneficial with external rotation, but meta-analysis has shown there is no differences. High chance of recurrent dislocation under the age of 30. So surgical treatment, it could be open or arthroscopic. Open, there are all age-old procedure with or without remplissage or the surgeon preference, how much of the glenoid loss, the humeral bone loss is there. So arthroscopic Bankart, standard posterior, posterolateral, anterior superior, anterior portals are made. Thorough 15 points examination is done. Look for the glenoid bone loss. If there is a controversy in the literature between some think that if there is a more than 15-20% of bone loss, they prefer a latar jet, or it could be, but absolute is if there is a more than 25% of the glenoid bone loss, go for latar jet procedure. So look for Hill-Sachs lesion, and according to surgeon preference, one can go for remplissage, or one can do the bone grafting, or even the glenoid bone graft should be considered. This is just a video demonstration. I'll just skip that video demonstration of suture anchor placement. This is just a follow-up of the Bankart patient which are treated. This is the 6-month results. Instability with the glenoid bone loss. Glenoid bone loss is extremely common after the shoulder dislocation. If goes unnoticed, the chance of arthroscopic failure is high, and percentage is at least the present in at least 50 to 90% of the cases. So glenoid bone loss is calculated mild if it is less than 15%, moderate 15 to 25%, and severe more than 25%. How to calculate the glenoid bone loss? Technique for assessing the bone loss is calculate the best fit circle at the inferior edge of the glenoid and draw a vertical line from the glenoid apex bisecting the circle. An anterior line is drawn perpendicular to the vertical line, and the A is like posterior glenoid to the vertical line and B is vertical line to the bone defect, and percentage of the bone loss is A minus B divided by 2 times A. There are various methods of calculating the bone loss, but this is the CT guided method, which pre-operatively you can consider whether you have to go for a Latarjet or you can go for Bankart. So this is just a pictorial from shoulder of arthroscopy, how much of the glenoid bone loss, and divide the glenoid bone loss from mild, moderate and severe, and accordingly you choose the procedure which is best for the patient and the results. So Latarjet procedure, there are different techniques like classic and congruent arc. Congruent arc where you matches the inferior surface of the coracoid to the glenoid rim, and these are the few examples of the Latarjet procedure which is done. This is just the video demonstration. The post-op result at 6 months and 1 year. He's a sports person. So coming to posterior instability, it is 4% of all glenohumeral dislocation. High energy seizures, electric shock can see from the repetitive use of stress, and 50 to 80% are missed at initial presentation and often present with internal rotated, adducted and upper extremity. Radiograph and like axillary views are essential. Posterior subluxation, apprehension sign. Treatment is depend on the reduction is necessary in emergency, traction, external rotation and abduction, immobilization for 4 to 6 weeks, surgical stabilization for chronic instability or dislocation. Articular fractures are associated more than 20%. Glenoid rim fracture can be associated and displace lesser tuberosity fracture. So humeral head replacement in case of chronic dislocation more than 3 to 6 months, or fracture of humeral head involving more than 50% of the articular surface. So I thank you very much for the kind attention. Thank you.